هشام. بسم الله الرحمن الرحيم. ربنا افتح بيننا وبين قومنا بالحق وأنت خير الفاتحين. صدق الله العظيم. صباح الخير عليكم جميعا، كل سنة وانتم طيبين، والجمعية بتاعتنا يا رب تكون طيبة ودايما تترقى من حسن إلى أحسن إن شاء الله. We shall start this session by our dear colleague دكتور هشام السيد. هي الدكتور هشام غني عن التعريف، وأنا مهما أقول يعني مش هعرف أوفي حقه. الدكتور هشام أستاذ الأمراض الباطنة وأمراض الكلى، ودايما بيجيب حاجات الفيشن بتاعته في الممبرين والكسسترا والحاجات الحلوة دي. فاتفضل يا دكتور هشام هيكلمنا النهارده. اتفضل حضرتك يا دكتور هشام.
Thank you very much, Mr. Chairman. Dear professors, colleagues, good morning. Hopefully that's the first talk in the 40th Congress of Nephrology of Egyptian Society of Nephrology. We will highlight some of this agenda of the intracorporeal dialysis therapy and moving to extracorporeal and biohybrid living endothelial cells, 3D printing, and back to reality with dialysis. We all know that the uremic toxins had not been well identified. Subsequently, its relation to disease is specific, and the comorbidities associated will highlight the target of therapy on dialysis. And the three-steps approach, including that identification, which is the representative new biomarkers, and its correlation to clinical symptoms and outcomes, and subsequently facilitating a personalized and targeted dialysis prescription to improve quality of life and mortality. The dilemma of the gut-derived uremic toxins and the protein-bound uremic toxins up to now needs attention, because all the hemodialysis modalities right now is lacking the dialysis adequacy of protein-bound toxins, and it's correlated directly to endothelial damage, especially picresol sulfate and others, and this is a vascular toxicity of endothelial damage and the vascular calcification. So the global epidemiology of end-stage kidney disease and disparities in kidney replacement therapy, where the incidence of end-stage kidney disease increasing rapidly, subsequently the dialysis population increased, while that the 5-year survival rate is still missing, correlating to renal transplantation. For example, USA just 40% survival on 5 years, while in Japan, the best dialysis modalities is 60%. So what is the future of dialysis to fulfill all the requirements for the patients? Should carry more physiological dialysis and renal tubular dysfunction, what's called the bioartificial kidney. What is the future of intracorporeal dialysis? It is nearly 40 or 50 years ago, where the future and the definition of intracorporeal dialysis, meaning peritoneal dialysis, injection of binders, intestinal dialysis using special materials like acacia gum and others, which permit the excretion of the toxin directly from the gut. So intraperitoneal dialysis, meaning that it is outside the body, no blood moving. It is just a dialysis inside the body. So novel intestinal dialysis intervention like AST-120, pre and pro-sympathetic supplementations, diarrhea induction, colonic irrigation. But currently, nowadays, the roadmap moving from first generation portable artificial kidney and going to the implantable bioartificial kidney, which we'll highlight very soon. The ambulatory wearable artificial kidney with dialysate regeneration by sorbents in BD and hemodialysis had gained closely attention right now, whereas in dialysis, either in peritoneal dialysis, you don't have to carry a lot of fluids. You can carry just a peritoneal fluid with sorbent adsorbent. So in hemodialysis and the peritoneal dialysis, in the next futures, we will have a sorbent-based modification and purification of a small quantities of dialysate that we are not in need to carry tons of liters of dialysate every session. So sorbent-assisted peritoneal dialysis, meaning that sorbent daytime system, it's only 2 kilogram, and single that at nighttime system, which is equivalent to 12 kilogram. And there is increasing in the research on the animal models in the goats, how much these serpents can attract the toxin and regenerate the dilazine. So the intracorporeal and extracorporeal promise basically the PD, the intracorporeal, hemodialysis without blood outside the body, the iHemo, implantable and bioartificial kidney, while the extracorporeal, meaning that higher membrane permeability, convection, HDF, more frequent and more prolonged. The ESN last year had identified a winner in the field of dialysis of intracorporeal hemodialysis, moving from the regular hollow fibers of a dialyzer into microchips or silicone paste. The target solution, including hemodialysis, which is the intracorporeal hemodialysis, using a displacer to the blood flow to move the protein-bound aromatic toxins from albumin, as well as the ambulatory kidney to improve vitality. So this is the winner, $650,000 USD last year, by creating a bioartificial kidney as a first step and a permanent solution. And the cells in the bioreactors could contain renal tubular cells. This is the renal tubular cells growth on the silicon nanofibers in a bioreactor, and this is the hole into the left panel, the whole device that will be implantable on the clinical trial very soon. So this is a patient still will need some medication like EPO because the current renal tubular cells will not produce. So what is the intracorporeal hemodialysis, meaning surgically implanted hemodialyzers? Hemocartridge that is constructed from the blood-compatible silicon nanopores and more flexible and more prolonged. Subsequently, when inserted inside the body, as a first step of the bioartificial kidney, is to use a nanofabricated silicon dialysis membrane implanted in a capsule and inserted inside the body, while the dialysate pathway is coming from the outside. So there is no fear of blood outside the body. The purification system is inside the body, while the dialysate pathway is outside the body, with the membrane characteristics, including the silicon nanomembrane, and this is the difference between regular polysulfone and silicon nanofibers. So iHemo, or intracorporeal hemodialysis and the portable device, gaining this success with the lab testing in vitro, denoting that there is improvement in the clearances of toxic solutes, and the implantable animal model had been successfully used as a first step of the implantable hemofiltration. It could be of value for survival and prolonged dialysis, improving all the outcome of dialysis. So this is the iHemo, and could be with a serpent dialysate-based system, so could be carried. And this is the winner last year. Again, there is another, is ambulatory kidney to increase vitality, backpack-sized artificial kidney for dialysis, and this meaning that if you have using a big dialysate volume, you cannot carry. But if you have using 1 liter or 2 liter of dialysate with a serpent regeneration, you can have success. And this is typically the regeneration of dialysate by using the serpents and excreting that into a nitrogen and CO2. Another way is the incoming is to use the microchips, which is the part of the computer system, very cheap, and to implant a artificial kidney inside with renal tubules, and this is around 15 microchips. It is very cheap, and it's very hopeful that it could be of a bioartificial kidney, and it is in the scaffold to inhibit the activation of the immune system via the renal tubular system. Another one is promising is the endothelial vascular graft for hemodialysis, where the vascular graft is inserted by an active endothelial cells, and these endothelial cells lining the graft has a probability, higher probability of survival and less coagulation, thrombosis, and infection. So this is a regular graft. However, these endothelial vascular grafts we can have in the clinical studies inserted in animal model has lower thrombosis and coagulation and could be in a hope of the more endothelial grafted, like in stents, cardiac valves, casters. What about the 3D printing? I have some experience in this field 7 years ago, where I can do by 3D printing a prototype. What is meaning by 3D printer? We can imagine on a computer system, then you can print, then you have a device in your hand, not on paper. So I used that 7 years ago in emergency, where in the UK had been asked me to do a very tiny filters for the neonates by the Newcastle Hospital. I shared that with Professor Malcolm at that year, and using the 3D printing technology, we can have a prototype of this dialyzer. Subsequently, this is a very infant, very small, tiny baby, has successful transplantation. Later on, as well by the 3D printing imaging of the whole abdomen between her father and the baby. So multi-layer scanning and the 3D printing as a kidney is a promising approach. Nowadays, what we have, coming back to the reality, we have to enhance the dialysis. We have a lot of uremic toxins, a lot of dialysis membrane, and a lot of dialyzers efficiently can remove toxins from low flux to superflux and high cutoff. While dialysis in home dialysis is increasing in demand, with the subsequently technology, you can have a home dialysis with a very small portable device. In Japan, we can have a membrane permeability. Right now, like high-performance dialyzers, we can have hemodiafiltration. We can use bigger surface area dialyzers. Will come into our Shams University result. So the dialyzer classification and the mortality, we are moving from low flux, high flux, because not all high flux are equivalent. So we are moving dialyzer classification into 5 classes. From class 1, which meaning that low flux, and type 5, which is the protein leaking dialyzers. These 4 under type and the 5 types of the dialyzers are called the high performance membranes and are using in Japan extensively and depends largely on clearance of the beta-2 microglobulin. On the clinical studies, the using of protein leaking and high performance membrane like superflux as increasing in the survival, decreasing in the morbidity and the mortality, which is risk relative value, meaning that on the long scaling studies, the benefits of such dialyzers with superflux had been achieved a very good result. So this is as well the Japanese renal dialysis system, meaning that hemodialysis is nearly 50% of hemodiafiltration, either pre-dilutional or in a post-dilutional way. Another biomarker is important. We highlight that early in this study, and one of the biomarkers is the alpha-1 microglobulin, because it's a very high pro-inflammatory material, and this could be removed easily by high flux if we are using hemodiafiltration techniques. Enhanced removal of protein-bound uremic toxins. We highlight earlier that we can use a material that displaces the protein-bound uremic toxin to come free. Then we can remove the free part of the protein-bound uremic toxin. One example is using of ibuprofen in this medium. Using X larger dialyzer above 2.0. I think in our experiences, we don't have an experience above 2.0. I did that 3 years ago. I innovate a dialyzer equivalent to 2.6 square meter in a superflux. We will highlight our results. So dialyzer surface area is now considered as a classification into small below 1.5, medium around 1.5, large from 1.6 to 2.0 square meter, and X large above 2.0. Using X large dialyzers had been as well proving that to be more effective in survival and decrease of the comorbidities with decreasing the risk value. So this is a membrane innovations. In the superflux, we can remove as much as 50,000 Dalton from the uremic toxins. In Hesham University, we did a lot of studies, including using very large dialyzer, what is double X size 2.6 in steam, and I did that 3 years ago in Budapest, first launch of performing such new dialyzers and new membranes had been achieved in the local market for clinical use with a wider range of Stephen coefficient, removing of Stephen coefficient of myoglobin of 0.7, which is the highest we can find. So our clinical studies done in Hesham University, we found that we can achieve a reduction ratio in hemodialysis and hemodiafiltration. If we are using hemodiafiltration, it's around 1.5 more than in high flux. We can remove alpha-1 microglobulin, kappa and lambda, interleukin-6, which is important in cytokine storms in COVID-19. So this type of membrane and this type of technique is identically, hopefully, that can treat a lot of patients with inflammation as well in patients with COVID-19. While the albumin loss, we are feeling of excess albumin loss in dialysis. However, the total albumin loss in our studies is still around 2 grams. We also discussed that before. We can have later transmembrane pressure. In our clinical studies as well, we can use beta-2 microglobulin reduction ratio approaching 80%. We can remove tumor necrosis factor. This is our own clinical studies, and we can remove asymmetrical dimethyl arginine using the hemodiafiltration technique. So, Mr. Chairman, the near future will carry insights toward more physiological, more prolonged and frequent application, and the current achievement for permeable dialysis membrane using XX large dialyzer is promising, and thank you for giving the optimum care to the hemodialysis patient. Thank you very much.
شكرا جزيلا دكتور هشام. You are stick to the time. A highly informative lecture. في 3 دقائق للدiscussion. Is there any question? Thank you very much.
شكرا.